This is Where We Live from Connecticut Public Radio. I'm Sujata Srinivasan in for Catherine Shen. In just a few hours, advocates pushing to reduce wheelchair repair delays will protest at the state capitol. Coming up, we'll hear from one of them. But first, disability rights advocates in Connecticut are demanding better medical access. This legislative session, they're asking lawmakers to pass two bills. Both aim to improve medical equipment and training and access to better care when examining, diagnosing, and treating patients with disabilities. Our producer Katie Pellico spoke to 8 people from the Citizens Coalition for Equal Access, a disability rights organization right here in Connecticut, on their negative experiences in medical settings. People like Sam Bodie in North Branford. When he needed to get onto his cardiologist's examination table, his mom and dad were right there with him to help him move from the wheelchair onto the table. Bodie says the doctor then told him, and I quote, "This is why you people," end quote, "should be treated at the hospital." Andy Bate in Windsor was a social worker for 20 years. He's helped people with disabilities navigate medical settings, but he also has first-hand experience navigating for himself. Let's take a listen.
In terms of my personal experience, one that particularly sticks out is when I went to a major radiology provider in this state, and they were like, "Well, we can't help you, you know?" And I was like, "Why not?" And they were like, "Well, you need to be able to walk to the X-ray table, and you need to be able to transfer yourself." I took one of their walkers, and I was able to just barely make it to the table, and with their help, I was able to get on the table. But they took the X-ray, and right after they took the X-ray, I heard in the background, "Looks good. Let's get him out of here." And not in a good way. It was more like, "This guy's a liability. We got to get him out of here." And then when I was done, they were like, "Well, you can't come back here. We're going to make you go to the hospital whenever you need X-rays." And I was stunned, to say the least. And the scary thing is that, that's just one experience of a multitude that everybody in this space now has experienced. So.
For more on legislative efforts and their hopes this session, we have 2 other members with the Citizens Coalition for Equal Access joining us now via Zoom. Dr. Cindy Miller, former Associate Professor at Yale, and Dr. Ruth Groby, Coalition Secretary. Welcome to both of you.
Thank you.
Thank you.
And you can join us too. Join the conversation 888-720-WNPR or find us on Facebook and X at Where We Live. Dr. Miller, I understand you have congenital muscular dystrophy, so you cannot walk and you use a wheelchair. Tell me how your disability combined with your medical training, you're a radiologist, is shaping your advocacy work.
Well, it's actually quite interesting. I was able to walk up until the time when I fractured my femur, shortly after I arrived in New Haven in 2001. And so my experience has really changed since I became dependent on a wheelchair. And shortly after beginning my work at Yale, I found for myself an internist at Yale who had asked me if I was interested in teaching medical students. And I said, yes, I would be very interested in doing that. And they conduct a session once a year for medical students right before they go on to the wards to begin their clinical training. Mm-hmm. And it's about disability and how it basically is just an introduction to disability for the students. And it's been really eye-opening for me. When I first went to teach this session, I thought maybe half the class would be there. They were all sitting there very attentively. And each year they present amazing questions to me about disability, because this is the introduction to disability for students who have been there in school for a year and a half. So after I stopped working as a physician, as a radiologist, I decided that I still had something left in myself to give. And so I pursued a degree in social work. And I discovered that advocacy was the area of greatest interest to me. And frankly, who better to advocate for than people like myself? I've experienced it, I know the story, and so that's what sort of informed my advocacy.
Ruth, how about you? How did you get involved with disability rights?
Well, like Dr. Miller, I have a master's degree in social work from the 1980s, and there was very little disability content in the curriculum of my school at that time. And so I was somewhat and since I did not know any personal family members or friends who used a wheelchair, I was under the impression that the ADA had solved everything for people with physical disabilities. Then I became chairperson of the Farmington Human Relations Commission, which is a commission of town government that's charged with promoting equality of treatment and opportunity for all residents of Farmington. And since in Farmington, there is New Horizons Village, which is an apartment complex that offers independent living for people with disabilities, I thought, well, why don't we have a Human Relations Commission meeting at New Horizons to see how everything is going for the tenants there? And there was a huge turnout of people. It turned out the institutions in Farmington, there were an enormous number of physical and attitudinal barriers that still existed for people with disabilities. It was a real eye-opener for me. I started to make friends with people with disabilities and see how the larger society pretty much still renders them invisible. And it's very hard for them to have their voices heard. So one of the Farmington institutions was the Yukon Health Center, where many of our Citizens Coalition members get their health services. And the Human Relations Commission was joined by a retired member of the Yukon School of Medicine faculty, Ray Elling, who was a wonderful advocate, disabled himself. And he put us in touch with Mary Beth Bruder, the director of the Yukon University Center for Excellence in Developmental Disabilities. And Mary Beth put us in touch with a group of activist medical students who really cared about the issue of physical accessibility.
Now, I just want to give a quick context. Ruth, you spoke about people with disability being invisible, and yet, according to the CDC, 1 in 4 adults in Connecticut have a disability. Now, that's an all-encompassing data. For example, the state estimates that roughly 43,000 residents have a developmental disability, but 1 in 4 adults. Now, Dr. Miller, I want to know from you, bird's eye view, a quick feedback about, what your hopes are for this legislative session. Advocates are pushing for 2 bills. One, as you know, is aimed at improving availability and access to medical equipment, and also importantly, training around the use of those equipments, like scales and X-ray machines, and the other is aimed specifically at lifts. What are your hopes for this legislation, this short session?
Well, certainly my hopes are, one, just to raise this issue before we accomplish anything very specific. We need to make this issue front and center because the physicians and most medical students don't realize how prevalent disability is amongst the patients whom they're going to be treating. That's number one. Before we even get to what our specific goals are. And then to make it necessary that everybody recognizes the fact that we must have the ability to examine our patients in their entirety, not trying to get by with the minimum, but to make sure that every patient with a disability is able to get a complete exam. And this means examining their entire skin surface for early lesions that may develop into melanoma if they're not more closely watched. It amounts to listening to their lungs, not only in the front, but in the back. And so by telling the physicians and telling the public what a complete physical exam amounts to, that is the way we're going to be able to best advocate for the use of equipment that is accessible to every patient who comes into the office, not only the patients who walk into the office, but those who ride into the office.
Now, there are laws. I mean, there are regulations, and we are hearing more and more from people with disability that they're falling through the gaps. So one advocate that our producer Katie Pellico spoke to, Jamie Mosier in Unionville, describes having to travel with an aide for medical visits to transfer him onto tables or scales, and a lift should be doing that job. He describes those medical tables as narrow balance beams. Now, there is a current law in Connecticut that requires medical facilities, and I quote, take into consideration the U.S. Access Board standards around disabilities. Here's what Jamie thinks about that.
You can take into consideration anything you want, but that's not good enough. We have to make a difference. Taking into consideration is just not enough. Something has to be passed to make sure we get what I need, or we get what everybody needs before we're all dead.
It's heartbreaking to hear. Dr. Miller, could you respond to what we just heard from Jamie? How common is his experience in this demographic?
His experience is very common amongst those with disabilities. My own physician had said to me at one time, oh, he could just lift me onto the table with one hand, which he could do. And then the following year, I went to see him for my annual appointment, and he said to me, well, Yale no longer allows physicians to pick up patients, so I can examine you in your chair. He didn't suggest to me that I bring somebody with me, but he made it very clear that he could no longer do that. So while the question of having an aide with me or an assistant was never raised, I can tell you about taking an assistant with me to an appointment, not because I expected that there were going to be any needs, but just because I wanted her to hear what the physician said. I found that the physician at that point spoke to my aide rather than speaking to me.
So one, of course, is patient doctor-patient relationship, interaction. And the other aspect is the thoroughness of the medical examination itself. And you explained, you being a doctor yourself, that it's important to examine a patient, who in both sitting as well as in a horizontal position. Otherwise, I'm assuming that there's certain symptoms could be missed. Dr. Miller?
Yes, in fact, the reason why medical students are taught to listen, for instance, to the lungs, not only in the front, but in the back, is because the lobes of the lungs really extend from the front of the rib cage to the back, and certain lobes have greater bulk in the back of one's body than in the front. So unless one specifically examines the patient from the front and from the back, it's very conceivable that they're going to miss things.
Thank you. Now, our producer spoke with Public Health Committee co-chair State Senator Dr. Saud Anwar about his involvement in drafting the bills. Let's take a listen.
Empathy should not stop at one specific area. We should be able to look at it as a much more comprehensive. But with respect to changing the environment, the structure, and so on, that is somewhat limited to the physical disability component. And I think that's where the federal regulations have been a little behind. So there were arguments that people were making that they said, well, we don't want to invest into a structure that about 2 years from now would become obsolete when the federal guidelines come. And my personal view is that we cannot wait forever for the federal government to come up with a solution or prescription for this. So we should start to do what we can and then at least create the entire, we don't even have a map, frankly, a map of all the hospitals, all the systems, all the healthcare facilities and their capacity. So irrespective of what and when the federal government is going to say something, are we ready to even implement?
Ruth, could you briefly comment on the federal ruling that State Senator Anwar talked about and why, in addition to that, state legislation is also important from your perspective?
Yes, Abhi. The U.S. Access Board, which is the technical body that makes recommendations as to what should be what kind of technical requirements should be required under various statutes. In 2017, they published standards for accessible medical diagnostic equipment, and that includes exam tables, as you've clearly heard, weight scales, X-ray machines, imaging machines, mammography machines, and those standards have been there since 2017, but they are only recommendations. And the federal government has made several attempts to turn them into regulations under the ADA or under Section 504, the Rehabilitation Act of 1973, but it's been an incredibly slow process. And there is rulemaking going on right now by both the Department of Health and Human Services and the Department of Justice. And the legislation we'd like to work on with Senator Anwar takes a lot of the language from the federal rulemaking, but there is no reason why we can't adopt it as a state before the federal regulations are finally passed.
And Ruth, what do you think? What do you think of State Senator's suggestion to map healthcare systems?
I think that will help. And I think however, we've been working for 2 years on an accessible MDE task force where the only thing that's happened has been some attempts at educating the medical community about the issue of accessible MDE. And I think without legislation, without adopting regulations, we're putting it off even further. And meanwhile, I've watched several members of CC=A pass away. And I think it's time to act. There's precedent for states going ahead of the federal government, and we have a legislation drafted that we hope we can work with Senator Anwar and the Public Health Committee on getting passed this year. In terms of the LIFT legislation, we have submitted some language in consultation with disability experts in Connecticut and nationally. And because lifts do not technically qualify as medical diagnostic equipment, but are critical to transferring patients with physical disabilities. It's important to improve the provision of lifts in medical facilities across the state as well. And I'd like to finally say that our effort, this is for people with mobility disabilities, of course, but our effort is part of a larger movement in the Connecticut disability community. Access to healthcare for people with disabilities is not adequate for people with intellectual disabilities and developmental disabilities. And so we're working as part of a larger movement to address the entire issue.
Now, MDE, a note to clarify for listeners, is medical diagnostic equipment. Now, Ruth, you were named a witness in a lawsuit filed Wednesday with the U.S. Department of Justice alleging affirmative discrimination against people with mobility disabilities in the state. Can you briefly tell us about this?
Could you repeat, please?
So you were named a witness in a lawsuit filed Wednesday with the U.S. Department of Justice alleging
yes,
affirmative discrimination against people with mobility disabilities in Connecticut. So can you tell us a little bit about this?
Yes, I first want to say that we would prefer a legislative strategy to address this issue, because filing individual ADA complaints puts all the onus on people with disabilities who are already struggling with the tasks of daily living and the barriers that exist in the society. And to take individual responsibility is not the strategy we want to go with. It's a systemic problem, and it needs to be addressed systemically. But there was one situation that was so egregious, and I helped a CC=A member. I was a witness when she called a local radiology company to try to make an appointment and was told that she couldn't be accommodated, or she was told that they only took people who used wheelchairs if they could stand and pivot on their own. And I overheard that phone conversation with the representative of the radiology company.
And you're referring to Miss Gurafa, am I right?
Yes. Okay. Yes. And the ADA complaint is based on the fact that is a violation of both Title 3 of the ADA and Section 504 of the Rehabilitation Act of 1973.
Thank you. We only have a few seconds left in this segment, and I want to end with your reactions to one clip. Producer Katie Pellico spoke with Suzanne Gurafa from West Hartford, who calls herself a fighter. Here she is.
There's no scales. There's no way to get on the table. When people go and you bring your aide with you, they talk to the aide. They don't talk to you. So what we're doing right now is I'm going to the legislature with our group to get things changed. We don't need people to come in and take care of us and say, you can't do this. You have to listen to us. All right? I'm not one of those people. I don't listen to what people tell me to do. I see what's going on and I try to change it. I'm not going to say that people don't care, but they don't care. It's very hurtful that I have to go to the doctors daily and I get told, we can't take care of you because you can't stand anymore. When I first came here, I was a person that stood. I was a person that stand. I had crutches. I had a walker. I can no longer do that anymore. So people are making you feel like you're not a person anymore, but that's not the reason why I'm here. The reason why I'm here is to help things change.
Heartbreaking. And even, I suppose, well-meaning people in the healthcare industry might not have perhaps thought this through, of what it's like to be on the other side. Dr. Miller, how would you respond to what Suzanne just said?
Well, I must say that I have experienced fairly similar reactions when people try to take care of me. I've had the privilege, though, that, for instance, as far as radiology goes, that I was a radiologist. So when I go into Yale and I say, I've come for an X-ray, they do everything they can possibly do to position the X-ray tube in a way that it can do the work that would normally be done by the patient moving him or herself. So I've not experienced exactly what Suzanne has experienced in that regard. However, having heard about Suzanne's experience with a particular practice in this state, I said to myself, well, I know radiologists who work in that practice. Let me see if this is really so. And rather than identifying myself as Dr. Miller, I just said, I'm Cindy Miller, and I use a wheelchair, and I need to get an X-ray. I wanted to find out whether you'd be able to accommodate me at your office. And I was told point blank, no, that's not going to be possible. And I thought to myself, is this really going on in 2023 when I made my phone call? I was just incredulous. So this is the truth. And this is the kind of thing that we are truly being activists about.
I'm so sorry that you and a whole demographic of our fellow citizens are going through this. You've been listening to members of the Citizens Coalition for Equal Access, Dr. Cindy Miller and Ruth Groby. After a break, we'll get an update on a related legislative effort to improve wheelchair repair times. We are hours away from a protest held by wheelchair users and advocates at the state capitol. You can join the conversation 888-720-WNPR or write to us your comments, your questions on Facebook and on X at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Sujata Srinivasan in for Catherine Shen. At noon today, wheelchair users will gather at the state capitol. They plan to protest in support of the Wheelchair Repair Task Force's legislative recommendations to tackle the, I quote, absurd delays faced by 90% of roughly 5,000 Connecticut consumers. Joining us now via Zoom, Jonathan Sigworth, consumer spokesperson for the Connecticut Wheelchair Repair Task Force. He is also co-founder of More Than Walking. Jonathan, welcome to Where We Live.
Hi, good morning. Thank you. I love the chance to be here.
Morning. I understand you met with a bicycle accident in the foothills of the Himalayas in Missouri, India, during a study abroad program. You were only 19 at the time when you were told that you could no longer use your legs. Since then, you've been back in India many times, even launching India's first wheelchair rugby team, I see in your short documentary. So where does all this passion come from, Jonathan?
Yeah, well, I mean, maybe one explanation is my sport of choice in high school was extreme unicycling. So I had always a penchant for kind of the odd and the extreme. And the adventurous. So that was really good preparation for life as a quadriplegic, having to learn how to balance and move and become independent, only being, not having any sensation or movement below my arms. But I mean, I guess another part too was, I grew up in a fairly religious family, and we had a very
We're having some audio difficulties, Zoom trauma. as I think we've
of
all grown to
self-worth,
call it.
and that no matter what happens to us.
Jonathan, hi. We lost you
Oh,
for
hello?
a few seconds, but you're back on now. Are you still here with us?
Can you hear me?
Yeah, I can hear you now. We can hear you. Yep. We lost you for
Okay,
a few
great.
seconds. Yeah, you're on now, Jonathan.
All right. Yeah. So I was saying, I grew up with a family that had a strong sense of self-worth and, purpose for the community. And as soon as I became paralyzed, I really believed that I was introduced into an amazing community, diverse community, that I really wanted to learn more about. And the opportunities to serve have just abounded since then. And that's really guided my life's work.
Mm. Incredible. In a moment, we're going to talk about your advocacy around wheelchair repair timeliness. But first, our producer, Katie Pellico, spoke with Gary Gross from Unionville. He has cerebral palsy, and after his wheelchair tilt broke, he had cancelled dentist appointments. Since that would allow him to tilt back to be treated, he got a call from the dentist who said he could no longer see him as a patient. And Katie Pellico spoke to him ahead of this hour. I wanted to get your response to experiences like Gary's. Is it common?
Yeah, I mean, when wheelchairs break, they break down significantly. A flat tire, something as simple as a flat tire can really get you stuck in your home. And then you have more complicated things, maybe dead batteries or broken foot plates. But currently, it's on average a 1 month wait time to get someone to come to your home in person. It's really making people suffer. And there's a lot of issues around that, and it's quite common. Almost every 6 months, if not more often, wheelchair users need a repair done.
Now, so I'm looking now at the flyer for the upcoming protest at the state capitol this afternoon. It's quite a powerful image. It's a bright orange sky, almost fiery, a sort of a call to action. And beneath it is our grand state capitol, and we have people. The post. I'm looking at people in wheelchairs in front, in a circular, forming a circular direction right in front of the Capitol, their fists raised, and, talk about wheelchair, as access to their freedom. And, when you put it that way, it's quite powerful. When you walk down the road in a grocery store and you see somebody in a wheelchair, you don't think of it as, it's their freedom, the mobility, the freedom. And I want to, what's for the agenda today? I mean, what can we expect at this rally?
Yeah, so I mean, that's absolutely right. We're going to be emphasizing that wheelchairs are our freedom. That's why we absolutely need 4 days, not 30. 4 days mandate for businesses to come out and provide in-home repair assessments. That's just to figure out what's wrong. And then another 4 days to get it repaired once all the parts and insurance authorization is complete. And those are really our primary demands. And today, what people can expect is, to hear a bunch of consumer stories, to hear about, our lives and what it's really like living in a wheelchair. I think a lot of the issues that people have heard on this program so far today, not being able to transfer onto an X-ray machine and all these things, there's just a lack of understanding of what living in a wheelchair really means and the real limits that we experience when they break and the complications of, we need to travel with aids, and there's logistic concerns, and there's safety concerns, and there's extreme time constraints that we live. And, the industry, both for wheelchair services as well as for insurance, are giving us severe pushback. They're saying no mandates. We can't afford to fix your broken chairs in less than 1 month. How many of us, if you rely on a vehicle to go to work, to visit family, to do everything you do every single day, our lives revolve around getting around in private transportation, it seems. If you had to wait 1 month for your car to get fixed, you'd go somewhere else, right? You'd switch companies. We don't have that option. We rely on our insurance. We can't pay for these expenses out of pocket, and we need government to to mandate these timeline requirements as well as reforms to insurance coverage. Otherwise, we're literally bedridden and developing pressure sores and adding more costs to the whole healthcare system, when we get even more hurt.
And obviously, from these experiences that we are hearing, the free market competition among wheelchair repair companies hasn't really worked, because it looks like everyone is taking just about the same time. And I see that your legislation, the push for the legislation, is also looking to eliminate the need for prior authorization for wheelchair repairs. So that would also shorten the time, is the hope, I understand.
Right. Yes. Well, I mean, there's the prior authorization, so that, just so people know, you need a prescription to get a wheelchair, but currently you still need a prescription to get that wheelchair repaired, which is ridiculous, right? If your insurance pays for your wheelchair, why do you need to ask their permission to get it fixed? So that's just needless bureaucracy. But the 8 days is significant. But, if you look at the timeline that the industry provided in our task force that I've been on in the last 6 months, it's 2 months, literally, is solely responsible for the wheelchair services companies due to their lack of staffing. 2 months is delay on their part. They have the parts in, insurance is passed, insurance coverage is provided, but 2 months of the delay is due to their own constraints. So that's what we're really focusing on.
Thank you so much, Jonathan. A real pleasure to have you on Where We Live, a consumer spokesperson for the Connecticut Wheelchair Repair Task Force. Tune into Connecticut Public throughout the day for coverage of the rally and more. Our state capitol reporter, Michaela Savitt, will be reporting from Hartford. Thanks also to Ruth Groby for your time. After a break, we'll continue the conversation with Dr. Cindy Miller from the Citizens Coalition for Equal Access. Also joining us, a UConn student working to improve medical access for people with disabilities. Join the conversation. We'd love to hear from you at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Sujata Srinivasan in for Catherine Shen. This hour, we are getting an update on one of the legislative efforts aimed at improving medical access for people with disabilities in Connecticut. Students at the UConn Medical School got together to form the Disability Interest Group. That's after they identified gaps in their own education to examine and treat people with a range of disabilities. Joining us now via phone, Carly Muleski, a student at UConn Medical School and a member of the Disability Interest Group. And still with us, Dr. Cindy Miller, member, Citizens Coalition for Equal Access. Carly, welcome to Where We Live.
Hi, thank you for having me.
Pleasure. Can you tell us about some of the updates to the curriculum that you've seen through your involvement with the Disability Interest Group?
Yeah, so with the Disability Interest Group, I'm fortunate to work alongside a lot of passionate medical students, both fourth year, first year, second year, all years, in organizing really various educational events and opportunities to volunteer. And this also involves curriculum review. And I've also had the opportunity to work on some of this curriculum. So the first week of medical school, first year students, we have a session that helps students develop the tools to treat patients with disabilities. And I really value this early exposure back when I was a first year. So I was really motivated to continue this. During the session, we touch upon very basic things like the definition of disability, equality versus equity, and liberation, even going further to addressing individual disabilities as well as the spectrum of disability, and get students really thinking about accommodations for these patients. And then continuing with that, we also have a public health course, which we call Vital. We touch upon disability insurance and the structure of how to approach patients with disabilities. And this can be anything from addressing access and accommodations in the office, ensuring accessible follow-up, and making sure that the care is patient-centered. And we also carry this into some clinical skills. We have our doc program, which we call How to Be a Doctor, and really focus on identifying these resources for patients. In the future, we really want to incorporate this work formally into the clinical curriculum, so practicing asking these questions on real patients and applying the resources.
That's great. Dr. Miller, can you talk about why having medical schools involved in this effort is necessary?
Well, it's absolutely necessary because of the prevalence of disability amongst the community. One cannot have a practice that is solely composed of non-disabled people. And as we've already mentioned, every adult or so many adults will become disabled during their later years that someone who is not disabled right now has a very good chance of becoming disabled. So this is a skill that needs to be incorporated into medical education.
Carly, tell me about you personally, your background. What got you invested and motivated in this aspect of medical care?
Okay, so back in high school, I was actually involved really early working with people with disabilities through the I Can Shine bike program. So I learned how teaching all these patients or individuals how to ride a bike really led to increasing their independence, and I was able to play a role in that and really enjoyed it. So through the opportunity, I learned that people with disabilities aren't really any different. You know, they're my friends, my peers, and it's really important for the entire world to see them that way. And I'm fortunate enough to carry this attitude into healthcare settings, as Dr. Miller just addressed, that many patients have chronic illnesses, disabilities, and they require really lengthy hospital stays or frequent visits with providers. So it's really important to just make those interactions as positive as possible for both the patient and the physician. And that includes having the appropriate equipment to evaluate them, as well as doing this in a timely manner.
Dr. Miller, now the system already has patient navigators, community health workers, but you've also raised the idea of doulas as potentially useful in a medical setting, sort of a parallel, the work of doulas to a parallel in a setting for people with disabilities. Can you talk about that? How would it work?
So my idea is, just as doulas are assistants typically in the setting of pregnant women and provide all kinds of assistance, not only, or I should say, a lot of emotional assistance. I am thinking that a doula could act in the setting of patients with disabilities as sort of a go-between between the physician and the patient. So the doula I could conceive of as being an advocate for the patient, a translator for the patient, perhaps even a reminder to the physician that the physician should be speaking to the patient and not to the doula, but that here is an extra person to kind of explain or navigate for the patient. Not so much as a person who can do the physical things that the physician isn't doing, but to be there as a go-between. And I think that's the same function, really, as a doula in the setting of obstetrics. So it's to be an active go-between between the physician and the patient.
And that would be the cost sharing, I suppose, would be on the part of the insurance company and the copay of the patient. And, perhaps, for people covered under Medicaid, some investment from the state as well to expand care. Am I right in my thinking?
I think you're correct in your thinking. I haven't gone quite so far as to figure out how the financing would be accomplished, but given the fact that I think it would lead to greater success and greater degree of satisfaction of both the patients and the physicians, I think financing would be accomplished given that realization.
If you were to name, Dr. Miller, top 3 misconceptions that contribute to these gaps in care, what would it be?
That people with disabilities do not have expectations that they are going to ever get complete exams. Can you repeat your question just so I'm certain I'm answering it?
Oh, yeah. I mean, the misconceptions contributing to gaps in care for people with disabilities. What would you say your personal experience and what you've observed are the top 3 misconceptions?
So I will again repeat the first one, that people with disabilities don't have the expectation that they are going to be completely examined and that they will be satisfied with less than a complete exam. I think that's number 1, 2, and 3.
Carly, would you briefly like to respond to that? I mean, what are the top misconceptions you've observed? Hello, Carly, are you here with us?
Sorry, I'm back.
All right. So what are some top misconceptions, top 2 or 3 misconceptions?
Well, some of the same things that Dr. Miller already addressed, but that the care should be different. There's different expectations. I think every patient should be treated on an individualized manner, and that involves, taking the time to talk to the patient, making it very patient-centered, and taking the time for a thorough exam. And yes, there may be some accommodations for each individual patient, but providers just have to be cognizant of that and open to tailoring their interviews and physical exams to that patient.
Absolutely. I think it filters down to the humanization of medicine. Thank you both. You've been listening to a member of the Citizens Coalition for Equal Access, Dr. Cindy Miller, and UConn medical student Carly Molesky. You can see images of some of the inspiring people you heard from this morning, including Suzanne Gurafa, on the Where We Live website. I'm Sujata Srinivasan. Today's show produced by Katie Pellico. Our technical producer is Kat Pastor. Download Where We Live anytime on your favorite podcast app. Thanks for listening and be well.